Well, thank you very much, Sue. I hadn't realised that I'd done as much as you've enunciated tonight. So thank you very, very much for that very kind introduction and a summary of my involvement with the PHN. Thank you. Okay. Good evening again to everyone, and welcome to our medical update in dermatology this evening. Our speaker for this evening is Dr. Tevi Wain, and Tevi practices general dermatology as well as subspecialising in women's genital dermatology and paediatric dermatology. She's trained under Professor Gail Fisher in women's genital dermatology and undertaken further subspecialty fellowship at the Children's Hospital in Westmead. She currently works as a staff specialist at Royal Prince Alfred Hospital, where she's involved in training dermatology registrars, and she's a lecturer at the University of Sydney in the Dermatology Masters of Medicine program. Now tonight, in no special order, she's going to talk to us about uncommon but not rare skin conditions that we should be able to recognise in general practice. She's also going to talk to us about skin conditions in systemic disease and just give us a very brief and basic primer on the use of the dermatoscope. So Tevi, thank you for being with us tonight and for sharing your expertise, and it's over to you.
Thank you. Thank you for the introduction. So I'll just share my screen so we can get started. And we'll start in the beginning. So this talk is as comprised of, as it mentioned, comprised of three.
Tevi, could I just ask you to share in a presentation mode, if that's okay? At the moment, I'm seeing your. There we go. That's it. Perfect.
So this talk is in three disparate topics, as if you will. So I'll try and link them a little, but they might be a bit disjointed. So we're going to talk about common, not so common skin conditions, some skin manifestations of systemic conditions, and some intro to dermoscopy. So getting underway with not so common skin conditions, and Dr. Piazza gave me a bit of a clue when I did a run through earlier this week, just about what actually would be appropriate for this section, because I had picked, of the 4,000 or so skin conditions, I had picked the rare 100, and he said absolutely not. It probably would not do very well in general practice settings, so I made it a bit more relevant. And so case one is a 14-year-old boy with a 2-week history of a red rash on his body, which is flaky. He's been unwell with fevers and myalgia 5 days prior to the onset of the rash. And when you see him, he has this presentation, and you wonder whether this could be psoriasis, whether this could be tinea, but you see this once in a while, and you take a closer look and particularly note the presentation of the scaling. If you can appreciate in this picture, the scaling has a very classic appearance of this collarette, of each of these lesions having this red ring, which almost clears in the center, and a collar that seems to be trailing behind. Collar of scale. So sorry, that's the wrong slide. It should be pityriasis rosea, and I'll update this when I give this presentation. So this is pityriasis rosea, and it's a self-limiting eruption which has a herald patch, and you can see in all these photos the herald patch, which is the larger of the lesion, which may precede the onset of the eruption by several weeks. And then it has this classic truncal distribution or centripetal distribution, with this predominant truncal involvement of the back and chest, as well as early proximal surfaces of the limbs. And what gives it away, as opposed to other papillosquamous conditions, is this classic scaling pattern of this inward-facing scale with that collarette. Although atypical presentations can exist, and it can muddy the waters in terms of coming to this very classic diagnosis. It's commonly seen in younger patients, so in children, teenagers, and young adults. And it can be in the context of some systemic symptoms preceding the onset of the eruption, usually fevers and any constitutional symptoms as well. But the cause is still unknown. It is possible that it has some links with a common HHV virus or other virus, and it seems to be quite seasonally, the incidence seems to reflect some seasonality. So perhaps it is linked with a viral etiology of some sort, but this is not yet identified. In terms of management, we tend to manage it with some topical, usually it's reassurance, and we tend not to need any treatments, but if they do complain of some itch, which is usually mild, some topical measures in terms of moisturizers, topical steroids, and generally what I find works best is a bit of gentle sunlight, and you often don't need to resort to any systemic treatments. So case 2 is a 26-year-old man with white patches on his arm that have recently developed. He's extremely worried that this is vitiligo, as he has some family history of vitiligo. And when you look, he's pointing to these areas on his hand and his arms, which show these hypopigmented patches. But if you look closely, you can see there is some funny scale here as well. And if we pay attention to the scale, amongst all the papillosquamous eruptions, this scale also has a classic description. It's called Fafaceous scale or micaceous, Fafaceous scale, which is actually a particular, stands for a particular eruption. When you ask him further if he has had rash anywhere else, he says he does get an intermittent itchy rash on his body once in a while. It seems to recur in summertime. And you say, you know, can I have a look? Let's take a look at what's happening elsewhere. You see this pattern on the same day, on the same patient. On the back, you can see a hyperpigmented macular and patch type eruption. And on the anterior chest and abdomen, you can see this erythematous macules and patches. So this is, so obviously I've copied the slides, and that's how the pityriasis rosea and pityriasis vesicular titles got mixed up. This is actually pityriasis vesicular, which is a yeast infection caused by Malassezia, and the Fafaceous scale came from a species of Malassezia called Malassezia furfa. We know that it can be caused by lots of different Malassezia species, and that's what confers the various different colors. Malassezia classically affects pigment production, and that's what results in the various different color patterns, and often they can have multiple different patterns in the same patient. For example, here he's got brown and also a white on one aspect of his body, and typically it's preceded by a redness that is a sign of when the yeast is or the condition is active. And the pigmentation can be a long-lasting feature well beyond the active infection. So that's something to watch out for and reassure patients. If they're just left with pigmentation without any scale, you can reassure them. A good way of testing for scale, apart from just looking clinically, is actually scratching the skin. And as dermatologists, we like to feel the skin for certain conditions, and we like to scratch the skin for certain conditions. So if you scratch the skin with a tongue depressor or a blunt edge of a ruler, you'll feel that there's this Fafaceous scale, this really flaky scale that comes about, and that tells you that the condition is still active. And if you just see a hypopigmented or hyperpigmented patch and you scratch and there's no scale, you can reassure the patient that the color will in time return back to normal. They don't need any active treatments. In terms of who gets it, it tends to be younger people again, more commonly seen in humid environments or patients that have been visiting humid climates, such as if they go traveling to Fiji or other tropical regions. Also seen in people that do a little bit more sweat-inducing occupations, physical exercise, and sit in sweat-stained clothes. It's usually asymptomatic, sometimes can be a little bit itchy. Investigations that are helpful include Wood's lamp. This is a nice little technique I use for quite a few things, including vitiligo, as well as fungal infections such as tinea, as well as yeast infections like pityriasis vesicular. You can shine your Wood's lamp and you'll see a blue-green fluorescence, which is very helpful. Whereas if it was vitiligo, you would expect no scale, first of all. And secondly, on Wood's lamp, it would be a bluey fluorescence, which is more suggestive of depigmentation. Treatment generally, if it is active with scale, you can use some Selsun or Nizoral or Pevril, or combination of these is helpful for recurrent cases. And if very extensive, you can use some oral azoles like fluconazole, and you would use it with the instructions to the patients about doing some exercise about an hour after ingestion, which allows for the medication to come out in the sweat and allows the treatment of these yeast species within the sweat glands and on the skin. So it's a good way of getting good good treatment response to oral azoles. Recurrence is common, and going through general skin measures in terms of reducing sweat sitting on the skin and sweat-inducing environments and climate is also important. So the next case is a 29-year-old teacher who presents with painful red nodules on her fingers over the last 2 months. Let's say they started around May, June. She had a similar eruption same time last year. And when you have a look at her photos as well as what she presents with today, this is what you see over various different time spans over the past 2 months. So they can appear as little red bumps that are painful. They can sometimes become purple and leave a little sore or ulceration. So these are chilblains. These are tender, itchy red to purple lesions. Often there's associated swelling, and they're usually caused by localized vasculitis in the context of exposure to cold or and damp environment. You tend to not see these in the freezing condition where the environment's a bit more drier. And it's also a condition you tend to see in young individuals more commonly. There is some association with connective tissue disorders, and it's important to rule out these associations in the first time that these patients present, because young females are more likely to present with chilblains and are also more likely to develop lupus. So that it's important to investigate appropriately when you see them. They're also linked with other hematological issues, and generally patients tend to be of low BMI and may have risk factors of smoking. Investigations, as I mentioned, you would look for associations, and these are worth doing. I do it on every patient that's referred. I'm sure in a general practice setting, you might see a lot more than what I see, but it's still worthwhile doing. I have picked up a few patients with elevated ANA and other hematological issues, so worth screening them. In terms of prevention, I always advise to avoid cold exposure, and we go through very detailed instructions about avoiding the cold freezer aisle of the shopping center, of the supermarket, making sure that they don't go out to take their dogs for walks early in the morning without gloves, mitts. They can use hand warmers within their jackets and in their coats. stopping smoking, and also this can affect feet and ears as well. So appropriate coverage and general measures for those sites also. Treatments, prevention is the key, but if they are still getting lesions, topical steroids help to reduce the inflammation, and usually they need quite potent topical steroids, diprosone ointment or betamethasone or diprosone OV, in fact, and also agents that improve circulation. So GTN, as well as sometimes I have had to put some patients, particularly younger patients, I find children, on nifedipine, oral nifedipine 3 times daily, starting on low dose as needed. So next case this is a particular case. It's not so common. It would fit under what Dr. Piazza might say is a rare one, but I just wanted to highlight this because I have come across this a couple of times, and it is a missed opportunity, and I thought this would be a good opportunity to highlight this case or this condition. So it's an 18-year-old boy who presents with 3-month history of flaring acne on a background of Crohn's, and was recently treated with high-dose prednisone for Crohn's with quick weaning, and he has developed quite severe painful bumps on his face, chest and back. And this is what you see a few months into his treatment. I have his permission to use his photographs. You can see that he actually had completely normal looking skin on his face and back and chest prior to this all happening. And you can see on this picture that he has what's called acne conglobata or fulminans, if I paint the whole picture. So he has quite cystic lesions, complete scarring of pretty much all his face, but bearing the periorbital skin. And even the nasal skin has some hooding, so that's even involved that area. He's got extensive cystic lesions, bleeding lesions all over his chest and back. This is paired with some systemic symptoms of fevers, feeling lethargic, unwell, anemia, and in some patients, they can also develop lytic bone lesions and feel really, really crook. So this is in fact acne fulminans, which is a rare condition, but can occur in young people quite suddenly. And there might be family history, but usually the cause is precipitous use of steroids, and that has been quickly weaned. So pulse methylpred for various reasons, usually for inflammatory bowel disorders, and acne conglobata, which is the same condition but without the systemic features, is more common and more likely to occur in patients with inflammatory bowel disorder. So we can often see it in the context where they've been given steroids for the inflammatory bowel disorder and then develop this terrible scarring acne. Sometimes we see it in the context of really high dose isotretinoin as well. So patients that were needing isotretinoin for acne conglobata that then develop systemic features and even worsening acne on the first, when they first start isotretinoin, can also have this similar presentation, and that's usually due to that purging and the flare up. And usually they have a genetic predisposition for severe scarring acne. And they've got really horrible symptoms. They can have enlarged liver and spleen, malaise, and systemic constitutional symptoms as well. And it's an absolute tragedy because the scarring is permanent, and there's not too much that can unwind that, even with the best laser treatments at our disposal. It's very tricky, very tricky. So investigations, usually you would do all the general bloods as well as some x-rays as well, because they can get lytic bone lesions. Urgent dermatology review. Unfortunately, these patients are often referred by other specialists and told it's just acne playing up, and thought it's coincidental, and just wait in line for seeing a dermatologist. And privately and publicly, the wait could be over 6 to 12 weeks. And this patient waited politely, waited for his turn, and with a referral to RPA. Mum called several a private dermatologist was knocked back because it was too difficult for them to handle, and unfortunately failed by several general practitioners, several dermatologists, his gastroenterologist, because this could have been he could have been seen earlier whilst his initial few weeks of acne was flaring. And the treatment is actually putting them back on the high dose steroids and weaning it very slowly, starting them on very cautious low dose isotretinoin, and really, hand holding them throughout the whole process so that you see them much more regularly. But his case actually, has been a big part of our multidisciplinary discussion in the recent times at RPA, and I think it's really important not to miss cases like this. So let's move on now to systemic disorders and skin clues to these, and why it's important. So cutaneous manifestation of systemic diseases are commonly encountered in general practice and may be the initial sign of an internal pathology. They may assist in making the diagnosis, and it's a good overlap between GP and dermatology, because oftentimes when I do diagnose these patients, incidentally, if they come for a skin check or for other reasons, I would send them back to the GP and ask for all these other investigations for internal manifestations of disorder. So it's actually really good overlap between the two specialties. So a few cases to illustrate this important feature of dermatology in helping diagnose skin conditions. A 35-year-old internal manifestations, 35-year-old physiotherapist with 5-month history of itchy red bumps on her knees, elbows, buttocks, and scalp, recent diarrhea and abdominal pain, no improvement with likelier topical steroids or oral steroids. And what you see are these excoriated erythematous papules, and some are, if left intact, are vesicular, and they're classically involving the extensor surface of the elbows, the knees, the back, buttocks, etc. This is in fact dermatitis herpetiformis. It's a symmetrically distributed, very itchy eruption. So that most people think of scabies in this context, and that's why I mentioned that they've already used Lyclia, and that's a good thought. But marry it with her systemic presentation of diarrhea and abdo pain, and this is in fact a manifestation of celiac disease. It has a very characteristic presentation and also a characteristic histopathology, and we'll talk about that. So it's a cutaneous manifestation of gluten enteropathy and celiac disease due to the fact that wheat in dairy can be digested and made into gliadin, which is then absorbed and deaminated by tissue transglutaminase. IgA autoantibodies to tissue transglutaminase can lead to gluten sensitivity or celiac disease in the gut. The very same process happening on the skin by epidermal transglutaminase leads to dermatitis herpetiformis. So the exact same pathology occurring by IgA autoantibodies. One is specific to the gut, the other is specific to the skin, both due to wheat exposure through the gut. And the histopathology is quite distinctive, and normally we do a biopsy for histology, looking straight under the microscope with some stains, as well as for a special test called diffuse immunofluorescence, or DIF, and that gets sent as a fresh specimen to look for particular immune pattern, and that is the classic telltale sign for dermatitis herpetiformis, where there's all these neutrophils lining up under the skin epidermis. So generally, these patients need to be investigated for celiac disease, so require a gastroenterology referral. There is a significant association with non-Hodgkin's lymphoma, which can occur in any part, not just blood, but also in the gut, lymphoma. So it's worthwhile referring them on and it's really important that they're managed with a gluten-free diet to reduce the risk of lymphoma. If they are sticking to a gluten-free diet, generally they do not need any other treatment, just like for celiac disease. They don't need any other treatment to control their skin eruption. If they are not so adherent to the gluten-free diet, Dapsone is the first line. These patients, surprisingly, I know we use steroids all the time as dermatologists. I find that steroids don't work as well as Dapsone because the primary pathology cell here is neutrophils, and Dapsone's excellent for any neutrophilic dermatoses. Case 6 is a 28-year-old student with a 3-week history of photoexacerbated red facial rash on cheeks and nose, recent joint pains and malaise, and family history of autoimmune thyroid disease. When you see her, you see this classic malar rash, which involves the convexities of her cheeks as well as her nose. And this is indeed lupus erythematosus. It's the most common connective tissue disorder, and it has a cutaneous manifestation in about 85% of cases. And the cutaneous features are involved in actually forming the diagnostic criteria. 4 of the 11 diagnostic criteria are dermatological. There's also the latest criteria, which is the SLIC criteria. It has 4 criteria. There are, unlike a systemic lupus erythematosus, lupus erythematosus on the skin has few different variants. We classify them broadly as acute cutaneous lupus, subacute cutaneous lupus, and chronic cutaneous lupus. And within these, there are multiple subsets. So when we look at skin lupus, we don't look at it just as, is it associated with SLE or not? We actually look at it as a few different variants, and each of them confer different risks and associations. So acute lupus is what we all classically describe as that fixed erythema on the malar eminence, and it tends to spare the nasolabial fold, which is a good clue to other red facial rashes like seborrheic dermatitis, which is a bit more scaly and involves a nasolabial fold. And it is classically photoexacerbated, and patients report that. There are often other cutaneous features with acute lupus, including oral and genital ulcerations, alopecia, which can be either scarring or non-scarring, and non-scarring is the part of the diagnostic criteria. And these patients will have a positive double-stranded DNA, anti-Smith antibody, which is pointing towards SLE. They can also have positive antihistone antibodies if it is drug-induced. And it's a very classic presentation. Subacute lupus, on the other hand, cutaneous lupus, on the other hand, is a different presentation, tends to present with these polycyclic papulosquamous eruptions, see these annular to polycyclic lesions on photoexposed areas. It tends to have positivity of Rho and La, or SSA and SSB antibodies. And about 30%, and in some literature up to 50% of these this type of cutaneous lupus is linked with medication, usually along the lines of TNF alpha inhibitors, plaquenil has also been linked, even though it's used in lupus, gold, non-steroidal anti-inflammatories. These are some other drugs that have been linked to subacute cutaneous lupus. Majority of these patients do not have systemic involvement, so often ANA, double-stranded DNA are negative. So even though in other contexts or non-dermatological contexts, you might say, oh, well, they're not lupus. They're still lupus. They're just a different type of lupus, and there's still a cutaneous lupus, but without systemic involvement. So they don't need to necessarily be managed with systemic treatments, or they may, depending on how extensive their skin condition is and how much it's impacting their quality of life. But generally, these patients don't have kidney, liver, other hematological abnormalities. Chronic lupus, there are multiple types of chronic lupus. Discoid lupus is the commonest of those, or the most classic of those. It tends to have scarring, and it presents in this classic pattern with dyspigmentation, hyper or hypopigmentation, with follicular plugging, scaling, and that carpet-tack type appearance, which is that follicular plugging, and significant scarring. So this is usually also not associated with a systemic involvement. So ANA, double-stranded DNA, is usually negative, and majority of the patients are actually well and have normal systemic function. So cutaneous lupus, when we see cutaneous lupus, it's important to review their systems in terms of other medications, other risk factors, as well as looking for other organ involvement on the history and physical examination. And then in terms of investigations, we will normally look for the various diagnostic criteria, including immunological, hematological criteria, and these are part of the SLIC and ARC criteria. Investigating those, as well as, we're dermatologists, we do a biopsy, we do a punch biopsy for histology, as well as direct immunofluorescence. And that's very classic appearance in lupus. And then check all the ANA and double-stranded DNA, as well as ENAs. Management for all cutaneous lupus, we tend to start with sun protection, and that's regardless of where it's occurring. Sun protect all over body, to the point that they're vitamin D deficient. So these patients need vitamin D supplementation, calcium, osteoporosis screening, all of that. Stop smoking if there is any smoking activity. And then also we start, like with most conditions, with topical agents, topical steroids, topical calcineurin inhibitors, and then hydroxychloroquine is a good usual systemic treatments to start with, and then oral prednisone, depending on if they have other systemic involvement, usually in conjunction with the rheumatologist as well. And then just for cutaneous lupus, without any systemic involvement, we may or may not start other systemic immune suppressions like methotrexate as well. Case 7, 26-year-old nurse with recent sclerotherapy for veins, sudden onset of rapidly expanding leg ulcers at site of sclerotherapy, seen by infectious diseases and surgical team, thought to be necrotizing fasciitis, 6-month history of diarrhea, abdominal pain, and weight loss in the background. And when you see her, you see this presentation with this one large undermined violaceous plaque with this violaceous border, and this ulcer that is quite extensive. And then you see another area, and she reports that each of these sites were treated with sclerotherapy. This is in fact pyoderma gangrenosum. This has a very strict criteria. It has a very classic presentation, although various subtype presentations do exist, but the ones that usually present are these ulcerated, undermined, bordered, violaceous bordered lesions. They're usually sudden onset with minimal trauma being the cause of induction of these lesions, with this idea of pathogy. And they can start off as a very innocuous pustule or papule, and then they rapidly expand. Generally quoted to expand at about 1 centimeter per day. Very, very painful. That's also a classic feature of this ulcer. For example, same patient describing a non-painful ulcer, you might think of venous disease in the context of varicose veins and other having sclerotherapy, but painful ulcer, very classic for pyoderma gangrenosum. It is ends up leaving cribriform scarring, and that's also a part of the diagnostic criteria. Cause is usually a very minor trauma and has quite distinct associations. Inflammatory bowel disorder, with ulcerative colitis being more commonly associated than Crohn's. Other autoimmune disorders such as rheumatoid arthritis and hematological conditions like myeloma and MGUS, as well as certain infections, medications, etc. Investigations, generally, we would do a biopsy from the edge as an incisional biopsy, not a punch biopsy. And we would send that off for testing with this suspicion. Obviously, if you biopsy an ulcer, you might just get neutrophils anywhere. But if you do the border, you'd see this beginning of that process, which is a very neutrophilic process with that classic appearance. We would also swab to make sure there's no infection and send some of the histology specimen for culture also. Blood test to look for associations, including Crohn's blood test, but also send them for Crohn's and scopes for Crohn's and ulcerative colitis with the gastroenterologist, and also making sure there's no underlying hematological abnormalities. And in this case, in her case, she has a history of what sounds like ulcerative colitis possibly. So treatment, generally, if it's mild enough, topical steroids, but usually when they're quite extensive, like in her case with significant pain, oral steroids are first line. These are usually kept at 1 milligram per kilogram initially until the pain subsides. And one of the diagnostic criteria is quick response to steroid in terms of pain within 48 to 72 hours. And then you can slowly wean them over time. Recurrence is common. And depending on the cause of the condition, improvement of the primary cause, like inflammatory bowel disease, can actually improve the outcome or the future lesions. Case 8, 31-year-old woman presenting with 1 year history of skin darkening and roughness in the armpits, recent polydipsia, polyuria, and background of significant obesity. And you see these velvety plaques with this hyperkeratonic appearance, which is hyperpigmented in the flexures of her neck and armpits. This is acanthosis nigricans. Acanthosis nigricans can be normal in children, and also in certain skin types, but you can have variants that are signs to internal disorders, including a sign of obesity, insulin-resistant states, such as diabetes, endocrinopathies, such as polycystic ovarian syndrome and Cushing's. Certain medications can predispose to acanthosis nigricans. There are familial cases and last but not least, malignant association. So particularly with GI, in about 60 to 70% of cases, GI malignancies. And usually the malignant cases are much more florid, rapid onset, quite extensive, and tend to have this picture under the armpits where you can see that skin tag, all of that warty verrucous change also. I just wanted to touch on some skin signs of diabetes finally, before we move on from the systemic features of cutaneous manifestations of systemic disease. So diabetes is a fairly commonly encountered condition, and therefore skin signs are helpful to be aware of. So infections of the skin, including cellulitis, furunculosis, thrush, are common in diabetics than non-diabetics. Patients with diabetes can develop diabetic bullae, which are non-infectious and just a result of having diabetes. And these are just clear, large blisters usually on the lower legs. Acanthosis nigricans, as I mentioned earlier, diabetic dermopathy, quite common in a third of diabetic patients. This thickening, hardening of skin over the joints and general dryness and thickening. Stiff skin and joints, or sclerodema adultorum, it used to be diabeticum, but the diabeticum got dropped out because there's a few other associations for this condition, but diabetes is probably the commonest. And that tends to occur on the back and on the trunk. Diabetic leg ulcers, skin tags, eruptive xanthomas and xanthelasma on the eyelids. Necrobiosis lipoica used to be called Necrobiosis lipoica diabeticum, no longer because it can occur without diabetes, but diabetes is the commonest association. And reactive perforating collagenoses, which is a type of itchy skin condition with lots of little bumps on the skin on the trunk. So we'll move on to dermoscopy. I think I'm doing okay for time. because we've got a little quiz at the end if you want to join in, and if you only have your devices, little phones or iPads handy so that you can join in on the quiz. It's just an interactive poll. So dermoscopy, I'm just going to cover why dermoscopy is important and what we use it for. So dermoscopy is a way of magnifying skin lesions or skin conditions to give us extra clues that are beyond just what the naked eye can see. It is also paired with illumination, so lighting as well as magnification. It's a non-invasive diagnostic tool, particularly helpful for pigmented skin lesion, and that's indeed how it was introduced. However, these days we tend to increasingly use it for other skin conditions as well, and I'll demonstrate that later. It seems to have up to definitely increase the accuracy with which we diagnose skin conditions compared to with naked eye, up to 35% more accurate, with more features being able to be clearly seen, thus preventing unnecessary excisions of benign lesions and helping early excisions of malignant lesions. And it has a polarized mode, which allows for more detailed in terms of off the skin, so not needing to touch the skin, and also highlighting through the skin, so transdermal structures like vessels, going beyond the keratin, which can actually affect the reflection on this of the image that's reflected. So that's another useful feature. So in terms of color, I did this last night, and you can see that I didn't make it all consistent. So in terms of color, these are 3 separate talks I've done in the past and I put together. So in terms of color, so when we do dermoscopy, we look at it in terms of color, patterns, structures, etc. And color is usually a very helpful feature. It can represent depth of a particular pigment when we look at pigmented lesions. So red usually signifies vessels. Black means that the pigment is on the top layer, the stratum corneum usually. Brown in the part of the epidermis, and gray usually in the papillary dermis, and then blue in the reticular dermis. Just going to demonstrate basic patterns. So reticular pattern means a cross pattern where you can see this pigment network. Parallel pattern where you can, usually in acral lines, where you can see these parallel lines, and you can see the acrosyringium where these single white bumps are. Sparing of the acrosyringium is a good feature, whereas involvement of the acrosyringium with the thick band of pigment is a feature for melanoma. So this is not a melanoma, this is a benign mole. Circles, sorry, the picture hasn't come out that well, but what you can see are these round circles, and that is kind of a pseudo network. You can get that with pigment, you can get that with vessels, and those circles are helpful to tell us what site. For example, this is on the face, which is forming a bit of a pseudo network with these circles due to hair follicles on the face. Clods, they can be various types of clods. This is globular, so think of them as big globules or big bumps or lumps. And then you can have cobblestone, which are even bigger clods. You can have dots, really tiny brown dots, which are pigment, or you can have dots that are red due to vessels, or you can have structureless areas, so areas that don't have any features. Patterns can be organized, or patterns can be disorganized. I think this is just a very basic thing. So special sites, so acral sites, so palms, soles of the feet have this pattern of respecting the pigment, respecting the furrows and the ridges of the hands and the feet, soles of the palms. And obviously this again is not highlighting the acrosyringium. The pigment is within the furrows, which spares the acrosyringium. You can see if you look really closely that the white dots, which are here, are spared with no pigment involved. And so this is a good sign. This, I normally have an acronym: friendly furrows and risky ridges. And that tells you If it's in the ridges involving the acrosoryngeum, think melanoma. If it's in the furrows sparing the acrosoryngeum, that's a mole. And this is another special site which I mentioned before, on the face. So you can see it's not quite enlarged enough, but you can see that they form a circle around all the pilosebaceous hair units. So we might actually do a little quiz. If you want to get out your devices, we might just do a friendly quiz just to finish off. Half the slides will be on dermoscopy, half will be on some systemic conditions. So we'll just start with these. So what you'll need to do is open up your browser onto the internet part of your devices, and then enter the this polev.com/Delta Dermatology 799 into your browser, and you'll come up with the quiz, and this question will be asked, and you'll see the more magnified version of it on your devices. So this, you don't need to go off the slide. You can actually go off your own device, which will provide you with a much better quality photo. And then you can start selecting your answers. Is it active? Can you let me know if this is active? As in, are you able to choose your answers? Dr. Piazza, are you able to choose your answers? Oh, great, great. Someone's responded, so sounds like.
I'm still trying to get to the site.
Oh, yeah, no worries, no worries. But someone's responded, or a few people have responded.
It will be working, obviously.
It seems to be coming up on my phone. It seems like you just click on one of the pictures from.
Yeah.
Great.
Great. I'll give you a few minutes, just a few more seconds. So in fact, everything on this slide, 3 out of the 4 lesions is a seborrheic keratosis. 1 is a melanoma. All right, great. So in fact, A is the melanoma. A is has that irregular kind of pigment network on the periphery. All the other 3 have features of seborrheic keratosis, horn cysts, the brain-like structures, all of that. So sorry, we don't have time to go into this in much more detail, but worthwhile if you're interested in dermoscopy. This is just a bit of a teaser to refer to some good texts. There's Kittler, which is a good text to go to. There are a few others, and I'm happy to provide resources to textbooks that you can read over the week in a weekend regarding dermoscopy, with good pictorial depiction of what you should be looking for. The next one, which of these is a melanoma? So you're not looking at a dermoscopic image here, you're looking at a clinical image. A few more seconds to choose. Great. So we should all be answering fairly quickly, because I think the answers, you don't need to log in again, so it's all up there. So so we're kind of split between B and C. Now, what if I tell you the next question is the dermoscopic images of all these lesions So it'll be interesting to see how you all answer for the next one in that exact order. So if you imagine A, B, C, and D in the exact order, I've put the dermoscopic image of the same lesions. See if that can shed a bit of light and if your answers change. A few more seconds to finish this. Okay, so we've changed. We're overwhelmingly on C, which is correct. So C is the melanoma. And I just wanted to illustrate how useful dermoscopy is just in this cohort. If we were to use a dermatoscope versus not use a dermatoscope, how our answers could change, how a lesion that we view clinically versus dermoscopically, what our conclusions could be. And this is a very good depiction of the utility of dermoscopy to allow us to help distinguish pigmented lesions. So A is in fact a seborrheic keratosis, and you can see that here, it's a SEB-K. B is a dermatofibroma, and dermatofibromas can look like this. I'm cheating a little bit because I often use a really good tool clinically for DF, which is a pinch the skin sign, the buttonhole sign, and that's a really good feature. And so obviously you don't have the advantage of that. C is the melanoma, and dermatoscope really gives you a good indication as to why that's the case. D is a atypical nevus, but not quite a melanoma. So, you know, our answers have changed significantly from kind of maybe cutting out B or C to definitely cutting out C. So, so it's a really helpful way to highlight that to you. Okay, next one. So we use dermatoscopes for other conditions as well. I use it quite commonly for hair conditions. So this is trichoscopy when we do it for hair. And what do you think this feature that I've circled highlights? What condition? Okay, so what we're actually looking at, in dermatology, you know, you see these appearance to things and you try to make them fit into a nice, neat diagram or picture. This we call an exclamation mark hair, and exclamation mark hairs are seen in alopecia areata. So what that actually tells us is activity of alopecia areata. When an immune attack occurs at the bulb level of alopecia areata, the hair shaft actually thins at that area where the activity is occurring. And the new hair has a point of weakness when it comes out in that portion of the where the attack occurred in that time. So this is that exclamation mark hair. If you kind of squint your eyes and look at it a little bit, you can kind of make believe that it's an exclamation mark upside in that direction, going into the scalp like that. And that's classic for AA. Lichen planopilaris, the dermatoscope usually shows perifollicular erythema and scaling around each of the hair follicles. And particularly if you see the frontal fibrosing pattern, it's a very good clue with some lonely hairs. Female pattern alopecia, you tend to see variable hair shaft sizes. So that is a feature. Clinically, you see that variable size, but histologically, it'll be described as miniaturization. And you also see less hair count per follicular unit. So normal is about 3, you might see 1 or 2, depending on the stage of female pattern alopecia. And then, tinea capitis, you tend to see these curly round hairs. So they just almost look like black dots, but when you look underneath, it's actually hair that's curled, and that's due to the tinea, the trichophyton attacking the hair shaft. Now the next one, what is this lesion? Okay, so you see this white structureless area with a peripheral vessel pattern. And this, again, I'm cheating here. This is a dermatofibroma. If you had that benefit of touching the patient, you will do that buttonhole sign and you'll see that it dimples, but you don't have that luxury. Melanoma sometimes can look like that, but this is a very classic central clearance with that peripheral vessel pattern. This is a free format. What is this dermoscopy demonstrating? First in, best dress, or write as many words as you can. Any other takers? Yeah, so I think you're doing all, there's a few people writing things, but I think you all mean scabies. Scabies is something that I use a dermatoscope to help with. This is the delta bomber sign. If you kind of, we try to make up all these pictures. So this is that triangle of a delta bomber sign, and that usually you see at the end of a burrow. This is the burrow, and under the dermatoscope you can even make out the mite, and you can actually, I normally scrape at that end, at the end of that burrow where that delta bomber sign is visible under the dermatoscope, and put it on a slide, put some potassium hydroxide, let it dry out and kill the keratin, and have a look under the microscope. You'll see the mite there. That's a very on-the-spot diagnosis for scabies, confirmation and all, and it's a very satisfying dermoscopic utility. Okay, now we'll just finish off with some systemic signs of cutaneous manifestations of systemic disease. You see a young patient with this rash on his leg. Biopsy shows it's an IgA vasculitis. Which of these statements is true? It's more common in adults, A. B, adults are more likely to have chronic kidney injury than children. C, 3 common organs affected are skin, lung, and kidneys. And D, most commonly caused by drugs. Okay, so a mixed bag here. In fact, IgA vasculitis or henoch-Schönlein purpura is more common in children. Everyone is agreeing on that. The 3 common organs affected are skin, joint, and abdo, but kidneys tend to have a long-lasting effect. So that the next one. Most commonly, we don't know the cause, but most commonly an infectious etiology, although we don't know 100%. And adults are more likely to, the right answer is adults are more likely to have chronic kidney injury than children. Often in patients that have this disorder, it might just present with a cutaneous manifestation in the first few weeks with maybe a bit of abdo pain. If we don't link it, do the renal function and keep initially. So I've had a few patients who present like this, renal function normal, bowel symptoms settle, but then if we don't keep repeating their renal function, we won't pick up that their kidney function actually goes off. So you start them on oral steroids and managing them, and then, you know, 2 to 6 weeks into their skin rash actually improving off the pred and the pred dose weaning, they'll actually get this renal impairment, the creatinine going off and the EGFR dropping, and then I tend to refer to a renal physician if I see that. Some patients only get cutaneous manifestations with a bit of abdo pain and that's it, and joint pain, but if renal involvement, then definitely keep monitoring. They need up to you know, a year or more of renal management and renal review in terms of regular renal investigation following the initial presentation. So long after the skin disease has subsided, they need to have ongoing renal screen to reduce their risk of renal failure. A small percentage do end up on dialysis. You see a patient with this rash on his eyelid. He also complains of progressive weakness in his arms and legs. Which condition could this be? Great, I guess we're unanimous on dermatomyositis. This is in fact a heliotrope rash. Other features of dermatomyositis include shoal sign, which is a red rash on the shoulders here, like a shoal, and Gottrin's papules on the knuckles, as well as on the elbows, Gottrin's sign. They can develop psoriasiform eruption on the scalp. They can develop mechanic's hands, which are looks like mechanic's hands with fissures and looks like dry, scaly hands. They can develop holster signs with the involvement of their, where the holster of a gun would be, a red rash there. They can have capillary loop dropout. That's another feature I use dermoscopy for, just to look around the fingernail there to see very enlarged and dropped out capillaries. So all of these are features of dermatomyositis. These patients, especially in adult onset, can have at least 50% risk of having a malignancy at the time, prior to, or in the future. So they need a really good oncological screen, as well as age-appropriate screening as well. And that's important. And I've picked up patients that have ended up in ICU with you know, breathing difficulties, and we went and saw the patient for the rash, ended up being dermatomyositis, breathing difficulty as a result of muscle effects on the respiratory muscles, but then screening, once we diagnosed the dermatomyositis, screening actually showed GI cancer. So it's a good skin manifestation of a systemic disease to not miss. Which of these is not a dermatological sign of neurofibromatosis 1, NF1? So you're seeing these skin-colored lumps. You're seeing these flat brown patches, these small freckles in the armpits, and these red bumps on the face. So neurofibromatosis is a genodermatosis affecting children. There is NF1 and NF2. NF1 tends to present with a neurofibromas, which are what you see on picture A, later in life, so adolescent and onwards, adulthood. In young children, cafe au lait macules in the first few years of life, and a certain number tends to predispose them to this. There are a lot of conditions that can cause multiple cafe au lait macules, and certainly having 1 or 2 is not a diagnostic criteria for a syndrome, but it is one of the conditions that is associated with multiple cafe au lait macules. And then axillary and inguinal freckling and freckling around the neck is also another feature. But D, in fact, is angiofibromas and is a feature of tuberous sclerosis and another genoderm. You see a patient with these painful nodules that have erupted on her legs over the past 2 weeks. This is the last question. List some associations or causes of this presentation. If you can just write down what you think this condition might be associated with. Great. Wonderful. So this is in fact erythema nodosum, very classic presentation on the lower leg. Can atypically affect other areas as well, like arms, but very classically on the lower legs. Erythema nodosum has this contusiform appearance, looks like a bruise, and actually colors like a bruise as it ages. So often you see when they're a bit longer into their eruption, they might get newer ones that become yellow, newer ones that are still red, older ones that are yellow, green, and so on. And they're quite painful. Generally, they're not in themselves very significant, but they're a type of vasculitis. And biopsy, if you're unsure, helps to confirm that. It's a very classic histological diagnosis. Associations are varied and many: infections, medications, autoimmune conditions, sarcoidosis, inflammatory bowel disease, hormonal conditions such as pregnancy, oral contraceptive pill, all have been associated. So another systemic, another cutaneous feature of a systemic condition. Thank you, guys. And just finishing off with some resources. This is a website that I designed with a pediatrician talking about common skin conditions. It has fact sheets for patients on pediatric skin conditions, skincare tips such as bleach baths and wet dressings and how to do them. I often refer all my patients that come for eczema to this website on detailed instructions on how to do this, and also some safety advice. Other resources, I often send my patients to DermNet for good information. I write for this this website as well, and then other resources that you might reach out to as well. Any questions or queries? That's the end of the talk.
All right.
I haven't gone over time.
No, well, thanks very much, Tevi. I've certainly learned a fair amount about skin conditions myself this evening, and I'm sure that my GP colleagues have certainly benefited from your talk. And your talk's generated a number of questions, so I'll just go through some of them with you. The first one states, my experience of pityriasis rosea is that patients are usually asymptomatic and well before the rash appears. And I must say that that's my impression as well. Maybe it's because one looks at the rash and doesn't ask about the prodrome. But how common is an illness before the onset of the pityriasis rosea rash?
At least 50%. And some literature reports up to 60% or more, 2/3 of cases. So at least 50% can have a prodrome. They may not link it because it can happen a few weeks before. So worthwhile asking, and it tends to be seasonal. So generally our winter, and that's another a potential link to a viral etiology.
Okay. About the use of Selsun, how do we use it? How long do we leave it on for? How often do we use it, and for how long?
Yeah, so with Selsun or Nizoral or those two mainly, if we're going to use it, they're sold as shampoo. I normally ask the patient to apply it on the skin, leave it for 10 minutes and rinse off unless they have underlying sensitive skin or atopic eczema, in which case they might actually not tolerate it too long. But 10 minutes is a good time. And Nizoral, ketoconazole can sit on the skin within the hair follicles for 72 hours. So you don't need it more frequently than every 3 days. So I'd normally say twice a week. And I like to use it in a rotational basis. So I might ask them to use Selsun one time, and the next time mix it up with Nizoral, and then go back to Selsun the next wash, and so on. So they just keep both in their shower recess and alternate between those. And I use it for other malassezia conditions, so seborrheic dermatitis for the scalp, as well as if it's on the face or anterior chest, they can put it on those areas. So you can use it for pityrosporum folliculitis in a similar fashion. So all other malassezia conditions, you can use Selsun and Nizoral. If you think they have much more extensive involvement, then Peveril lotion, you buy it and put it on 3 nights in a row and use that. That's another option. But generally, I find oral azoles work quite well to just hit it on the head if it's quite extensive.
Okay, now what about the use of Selsun and Peveril in pregnancy? Any problems there?
So I still use the 1% Selsun in pregnancy. Usually, it's a wash-off treatment. It's not an issue. I don't use a Peveril as much, and I've never given it actually. I just say if it's needing Peveril, let's just go to azole. If they're pregnant, I don't use any oral azole, but you can manage with Selsun and Nizoral.
Okay. A question about chilblains. Have you seen chilblains associated with COVID? We heard and read about COVID toe. Yep. Can you tell us about that?
Yeah, so I have. I mean, I'm seeing quite a lot of COVID-related rashes. Whether it's due to COVID or it's just winter, I don't know. And some of these patients, certainly it's their first time ever getting chilblains, and they're anywhere between a 15-year-old girl I've seen in the last couple of weeks to women in their late 20s, all getting chilblain for their first time, all have had COVID for the first time. So I don't see them in the acute phase of COVID, but it is an acute sign of COVID. It's another type of vasculitic change that COVID induces. But these patients have generally have a classic exposure to cold, keep getting it long after COVID. So it's a documented feature now of COVID, acute COVID, but I see it, patients say, oh, could it be COVID? I've looked it up. Could it be COVID? And I say, well, it can be related to COVID, but you're having it well after you've recovered from COVID. So we'll put this down as normal chilblains and just do some workup for lupus.
Okay, there's a question here about keratosis pilaris. And can I say, please feel free to ask questions, not necessarily about topics that have been covered this evening. But with regards to keratosis pilaris of the face and the arms and the legs, the question is it ever associated with anything else? Fatty acid deficiency is something that our questioner quotes that she's heard people talk about. And what is the best treatment, as it often troubles young women for cosmetic reasons?
I mean, it's one of the commonest things I see patients for incidentally if they come for skin check, and some patients just book in to talk about keratosis pilaris. It is a very common autosomal dominant condition which affects large population in variable phenotype presentation. So even though phenotypically a lot of us are affected, phenotypically not all of us have enough to see it as a medical condition. When it usually is isolated in most cases just to the arms, extensive surface of the upper arms. However, sometimes it can be more generalized, involving the thighs as well as the face, including involvement of the eyebrows with loss of the eyebrows and this red scaly cheeks. As a condition, it tends to get better as the child grows older, and there's usually, it's autosomal dominant, so parent that has it in variable degree compared to the child. I normally encourage in children not to treat because they're not usually bothered. And if it's very limited, it'll tend to get better as they get teenage years and adulthood. If they're still bothered at an age where they're motivated for treatment and not the parent motivated, then start with topical keratolytics like salicylic acid in easy formulations that are available without a script, because they're going to have to use this lifelong if they want to really maintain this, because there's no cure for it, as well as lactic acid urea, which is a humectant, not a keratolytic, but a humectant. All of these reduce that follicular plugging with that scale and reduce that sensation of bump or lump and roughness. There is a red component to it, particularly on the facial keratosis pilaris faciae. There's a red component to it, and that can be treated with laser, vascular laser, and also on the arm if it's just a red component. But most patients are usually bothered by the roughness, and that can be managed with topicals. I have seen a few patients in the last few years who have whole body keratosis pilaris, and usually they're well, no association with any nutritional deficiencies. They have a strong genetic predisposition. Other associations with KP are atopic dermatitis and ichthyosis vulgaris. And these patients do benefit from oral acitretin. So patients that have it all over body, generalized keratosis pilaris, I say they're really uncommon compared to how many people actually walk around with mild KP. They benefit from acitretin if they're non-childbearing age female. So men, young men, older women, I put them on acitretin. If they're young women, sometimes isotretinoin helps as well. But that's, you do it until you're not bothered by it anymore, which they have to come to terms with. Yeah.
There's a question about courses for dermoscopy. Anything you can tell us about there?
So I'm involved in the modules. Dermoscopy is one of them, run by the Australian College of Dermatologists for GPs. I do the vulval modules, but there's ones on benign conditions, malignant conditions, other skin inflammatory disorders, etc. And those courses are helpful. Before I got into dermatology and I was contemplating general practice, I was doing certain dermoscopy courses, including from Health Cert. And there's also courses with the UK. I can't remember the exact ones, but I did look into those as well. So they're worth doing if you want to be an expert at it. So doing further studies specifically on dermoscopy will be worth your while.
There's a request for you to reiterate the workup for chilblains that you had mentioned.
Yeah, so chilblains can be in association with autoimmune pathology, particularly lupus. Another variant of it is called chilblain lupus, and histology in itself is not very helpful to distinguish between chilblain and normal chilblain without any bad associations versus chilblain lupus. So ANA, double-stranded DNA, ENAs are helpful, plus also hematological conditions. So worthwhile looking into cold-related vasculitic conditions like cold agglutinins, cryofibrinogens, doing those studies as well to rule out potential other causes of cold-induced vasculitis or vasoconstriction.
Again, just very briefly, what percentage of salicylic acid for the treatment of keratosis pilaris?
So you can go as high as you want depending on body surface area. So we don't want salicylism if they've got extensive involvement of their body and you give high percentages. But if it's just a focal area, and you can go up to, 8%, 10% if you need to. But those are usually available on a script. And if this is a lifelong condition, patients will get quite sick of coming to you for scripts. So you can do, 5%, 8% salicylic acid for small areas if they're really motivated. Otherwise, point them towards what's available at the pharmacy, like Calmurid, Lanate, Uriderm, which are other active ingredients, have lactic acid or urea, which are just as effective, and they don't need to see you for lifelong scripts for this condition. So that's another option.
With regards to oral azoles, the question is, which is the best in dosage, please? You did mention fluconazole. What's the dosage for that, and do you use others?
Yeah, I mean, I generally stick to fluconazole. It's cheaper now and very safe. I've had lots of experience using it in the context of chronic thrush, daily 50 milligram for 6 to 12 months if needed for some women that really need it. So, and we have lots of data on how safe it is. So fluconazole, generally I use that at a 50 milligram dosage. And I use it for conditions like seborrheic dermatitis, other malassezia conditions like pityriasis vesicular that's extensive. And I typically, for these conditions, use it daily for a week and tell them to exercise at least an hour after ingestion to get it out in the sweat. Then I use it once a week for a month, and that's it. And then my script usually will last them for another same amount of treatment, so another 2 weeks worth of treatment, if they have it again next summer. And it's a summer commonly recurrent condition, so they don't want to keep seeing you every year. So it's nice to just give them enough and direct them how to use it in the future.
Okay, that leads me into the next question that says, would you count recurrent vaginal thrush as a dermatological condition? And if so,
it is, yeah, it is, I guess. I mean, it's a condition that I diagnosed just by looking and on story. So, generally tests are negative, can be negative. So it is a dermatological condition. It's one of the commonest conditions I treat in vulval as a part of a vulval dermatology practice.
Yeah, but any particular treatment pearls to offer?
Yeah, so these women don't treat them as acute thrush. They need sustained therapy. It's now clear that this is not a true infection, rather a change to a microbiome where Candida has made a nice little home in their vulval and vaginal mucosa, and they've developed an immune response, if you will, or like you can think about it like an allergy, although allergy in dermatology is a very specific immune process. It's not true allergy, but you can think about it almost like they're allergic to Candida that's now part of the microbiome. So you have to have a way of making it unfavorable, and that's with sustained treatment. And some women, it's 6 weeks of daily treatment with fluconazole, some women up to 6 to 12 months. And usually, in my experience, they will need maintenance regimen long-term. Even if they happily go away and come off treatment 1-2 years later, they come back going, I need to start it again. Can you get me started? So, and they have, Gail published the latest study on chronic thrush or vulval condition, and she showed that patients with chronic thrush have the highest improvement of quality of life compared to lichen sclerosis management or lichen planus, which is a super painful condition. So often these women are very debilitated by this condition and are very thankful to be treated.
There is a question here about managing rosacea. Now that could be the topic of a whole other talk, so I don't think we'll have time for that. So the last question, and I apologise to people who've asked questions that we're not going to be able to answer, but the last question refers to a patient that one of our participants had with one small nevus sebaceous on the scalp. When is this significant, and can it be associated with systemic disease, cerebral disease in particular?
So sebaceous nevus. Sebaceous nevus is a birthmark, usually present at birth, with associated alopecia, usually on head and neck region, most commonly on the scalp. It's this warty growth, and it can grow in proportion to the child, but it becomes more warty and more verrucous and more irritated as the child reaches teenage years, and it can then become a bit more cumbersome for grooming if it's large enough and get caught in hairbrush, etc. Generally, we just monitor it. There were previous studies which showed that there was malignant transformation, particularly with BCCs within these lesions. We now know that they're not less likely to be BCCs, but a very commonly histologically mistaken condition with BCC, another type of benign tumor called trichoblastoma, but it doesn't matter. They can have other benign change. Any change in sebaceous nevi need to be reviewed to make sure that it's not a malignant change, and generally they're not associated with anything if they're single, isolated, not segmental. But all epidermal nevi, of which sebaceous nevi are one of them, can have syndromic presentations. I hope I made that clear. So if it's segmental, like in a large pattern in a V1, V2 or V3 pattern, or if it's associated with any eye changes or etc., there can be underlying syndromic associations. They're part of the genodermatoses, which I love, but we probably don't have time to go into. Yeah.
No, look, I am very conscious of time, and I do want to give our next speaker at least a few minutes to speak to us. So, Tevi, thank you very, very much for your wonderful presentation this evening. Thank you.
Thank you.
Our next contributor is Dr. Angela Russi, and Angela is a GP from the First Avenue Medical Practice in Five Dock, and Angela is just going to give us a bit of an update on Sydney Health Pathways. Angela, thank you.
Thanks, Dr. Piazza. I'm one of the clinical editors for Health Pathways. Sorry, Tevi, I just need you to unshare your screen so I can share mine. Thank you. Okay, so Health Pathways, for those who aren't aware, is a portal designed to support primary care. So we've got hundreds of pages on how to assess, manage, and refer if needed. So basically, I'm just going to give a little reminder, hopefully, about Health Pathways, how to use it and where you access it. So these are the links here. So we've got two different regions here present tonight, I believe. So there's the southeastern Sydney region, which covers the area of Prince of Wales, St George, Sutherland, St Vincent's and Sydney Children's. And then there's the Sydney region as well. So that covers RPA, Concord and Balmain hospitals. So we've got the links up there if you're interested. These QR codes will also take you to the front page of Health Pathways. So when we go to the front page of Health Pathways, basically what you want to do is you want to look up the condition that you're interested in. So what I might do is actually just show you how we do that for, say, dermatology in this instance. So we might pick psoriasis as our example here. So this is the Sydney Health Pathway. So if I type in psoriasis here, then it brings me up the psoriasis pathway. So we can click that. The first thing that you want to do is just expand all. So there's a number of menus within the, or text boxes, I suppose, within each pathway. So if you expand all, then you can go down and you can see essentially how to do the assessment of someone with psoriasis. Here, there's the different types of psoriasis. And then we go on to management. And then further down here is, when we get their request. So that's how you refer someone to a subspecialist if you're wanting assistance with management there, and then just some info at the end for both for us health professionals and for patients if it's needed. So you can then search within the page if you command, oh, I'm not sure if I'm allowed to do that with my share screen, but if we command F, you can look up something. So for example, if you type in scalp, then it will bring you to the scalp psoriasis section. So that can be helpful. I just jump back to my, oops, my presentation, sorry. There we go. So within each of the pathways, then we have dermatology sections that cover the most common dermatological conditions. So just to show you how we get there. So we've got this side panel here to show you how to get to the dermatology section. So if you go off to the side, dermatology, and then it lists all of the conditions or treatments or health pathways that we have under the dermatology section. So Southeastern Sydney have recently updated their skin lesions section, and it's quite comprehensive. I'm currently working on the Sydney region's skin lesions pathways, so they should be available in the coming months. We do have a capability, or at least Southeastern Sydney have the capability to nominate yourself as a colleague who will accept referrals. And so there are different specialty areas that you can nominate yourself for, one of which is skin cancer checks and skin cancer excisions. So if you're a GP that's interested in doing skin cancer work, then you can put yourself forward here. You can contact Sue Baker on that email address there and nominate yourself, so that GPs who are less confident with doing skin cancer checks and skin cancer excisions can refer on to you rather than clogging the private dermatology systems. There's also the opportunity to provide feedback on the health pathways. So ideally we review them every 3 years to make sure that they're up to date. But if you do notice an issue with one of the pages, there is this little text box feedback icon at the bottom of each page that you can type in a message and let us know if there's an issue, and we can update it and fix it. So these are the important people at Health Pathways. So you can contact them if you've got any questions or concerns. And again, you can use the blue feedback icon if you are wanting to let us know about something. That's that.
Okay, well, thanks very much for that, Angela. I know that I've been using Health Pathways of late, and it can be extremely useful. So thank you very much for the tips on it for tonight. Look, I think that just about brings us to an end, bar one other thing that I do need to mention. Christina, I don't know whether you're going to mention this as well, but the feedback will follow. Will that follow on now?
That's right.
For everyone
it will pop up directly on your screen after we close the session.
All right. Well, thank you very much for that, and thank you to everyone for being with us tonight. It's been a great presentation, and I'm sure that you've learned, as I certainly have, things to implement in your practice when you get back there tomorrow or whenever it's going to be. So thank you. And Christina, up to you for the wrap up.
Thank you so much. Look, I just want to share my appreciation to all the speakers this evening and our facilitator, Dr. Peter Piazza. It's been such a great presentation, being so interactive and actually, you know, making us question and look at things this evening. So thank you very much for the great presentation this evening.